Welcome to another episode of Let's Talk Small Data with T, where we are passionate about the power of small data in healthcare. I am your host, Tanazia Gonzalez, but you can call me T. Data has certainly changed the game in healthcare. Big data has blown the roof off, but small data, now that's the future. Small data allows us to dive deep into the key insights and take quick, customized action to achieve phenomenal results in performance and quality improvement. Let's explore this today. Thanks so much for joining us. If you have any questions for me or any of my guests, feel free to reach out to me at tgonzalez@eima-inc.com. Enjoy the show. Let's go. Welcome to another episode of Let's Talk Small Data with T podcast, where we explore the power of small data in healthcare. Today, I'm so honored to have Dr. Steve Tierney of Alaska on the show. Steve is Senior Director of Quality Improvement for Southcentral Foundation's Malcolm Baldrige Award-winning Nuka system of care. Steve played an integral part in the design and development of Southcentral's data infrastructure, which is allowing them to do some phenomenal things today, which we'll hear more about today. Steve is a family physician and acupuncturist. He maintains an active family medicine practice in Southcentral's Anchorage Native Primary Care Center. And Steve presents nationally and internationally on transforming primary care, data integration, clinical quality program design, and complementary medicine integration ethics. Steve is very busy. Steve, thank you so much for joining me today.
Thanks so much. It's really good to see you again.
Good to see you. And let me make sure folks can actually see your face. 1 second. There you are. Hello. Welcome to the podcast. So happy to have you here. You know, I'm a huge fan of yours and Southcentral, so I'm really excited about the discussion today. And I'd love my listeners to learn all about the great things you guys are doing with your big data as well as your small data. I'm really inspired by you. And as I told you before, it was your model that inspired the one thing I've created in my career that I'm most proud of. So I consider you all big time in my life. And I can see right now you're on mute. If you can go ahead and unmute
I got it.
yourself.
Yeah.
And just tell us a little bit about Southcentral Foundation. You know, what is your mission? Who do you serve? Who are you?
We are a Alaskan Native and American Indian based organization. We're in Anchorage, Alaska, where our headquarters are, but we serve 70,000 Alaskan Native American Indian people throughout the sort of south central area of Alaska. That is a geographic area that spreads all the way to the end of the Aleutian chain, where you can actually see Russia from your house. That's a little bit of a Alaska joke there. But it means that, you know, some of our clinic locations are hundreds and hundreds of miles out in the middle of the Aleutian, chain in the Bering Sea. So we have to be very good at sort of teleconnecting, wiring us together, but also being organized as a system. One of the most important things is we want to not just do the pills and the procedures. We want to make sure we're taking care of the mental, spiritual, and physical wellness of all the people that we serve, including the workforce that we employ. So it means it's not just a matter of doing something at any cost, at any expense, at any price. It's making sure you have a sustainable system that doesn't crush the spirit and will from your workforce, you know, as you do it.
Wow, I love that. Not a lot of organizations are paying attention to that. So I love that. I love that. So I know that you all have a very powerful story around data. And I know you played an integral part in that. Just tell us a little bit about how the data and the whole infrastructure has evolved at Southcentral and kind of what has that allowed you to do today?
Well, it's really funny. This is sort of a pivotal moment in my life. This is in the late 1990s, and I was a young, just not too terribly long out of residency, and they needed somebody to be the quality physician. So being sort of inexperienced and unaware, I immediately volunteered. Um, that's because no one else would make eye contact in the room. And I didn't know what that meant, but it sounded good, quality. Why wouldn't we? That should be great, but what does that mean? And at first, they said, well, you need to check on how we're doing with vaccinations and cancer screens and diabetes and stuff like that. So I would run around and gather data and, work with people, and they would give me these, spreadsheets, and they would say, well, your performance on breast cancer screening is 56%. And I would say, okay, well, I'll tell the fellas and we'll fix that straight away. And this is funny because this is in the late 90s. I would carry gleefully my numbers back to the workforce, and they would say, well, that's just fake news. No, that's just not true. I know it's much better than that. And I would say, but I worked for weeks making this very pretty graph. Look, it's got different colors on it, and they say, yeah, that's wrong. Well, okay, I'll go back. And, so what happened over time is, we began to say, how about we give you a list of who we think you did and who you didn't. And then you can check us. And then we had to go a step further to say, and by the way, if you find any errors, you can let us know. And so over multiple iterations over time, we actually began to get the beginnings of a trustworthy data system that we felt that was only successful if the workforce believed it and could in fact verify it. So what I began to be is more the liaison between the data people and the clinical people to say, here is what we think we're measuring. I'll have the guys check it. And if they say, yes, that in fact is the truth, then we will proceed and we will move on into that's an active measure. Well, what was funny is we have these questions that would come up, where we would, begin to say, okay, well, that's great. We've gotten sorted out with the vaccinations of the cancer screens and now the diabetes and some other stuff. But what about people on anticoagulants? How about heart failure? How about, other things like that? We should do more, And what happened to us is we realized we couldn't keep up with building these new things because once the workforce trusted, that they could actually veto if they thought it was incorrect, then they started to ask all sorts of questions. So we started to literally not be able to keep up. And we started to say, wow, it's funny because they're asking the same sort of questions each time. They want to know the name and the phone number and the age and the gender and the medical record number and who they saw and then fill in the blank for did they have that done or this done. And we started to say, well, why don't we just save these things? They ask them pretty much every time. If we begin to archive all of them. And so what we sort of slowly evolved to is we said, why wouldn't we just continually keep all the meds and all of the basic labs, not every lab, but the basic labs, and then all the encounters, and then all of the sort of name, address, phone number, demographics, and all that sort of stuff. And that's when we began to run into the genesis of what I call the pantry, is when you put this in a cloud server and you use, some sort of spreadsheet analytics tool on top of that, then you can begin to click and drag all those who have click asthma, all those who click are on this particular inhaler, all those who have a BMI of greater than this, who have a weight greater than that, who have a, who have been now fill in the blank admitted to the hospital in the last 12 months. And what we began to notice is there were patterns emerging. And what was interesting is at first we said, well, it's got to be diagnosis. Here's the funny thing about diagnoses. So if you came to me as a family doc and you said, Doc, I got this really bad headache and it's, killing me and it's making me crazy. I can't sleep, And I would say, well, geez, see, you don't really complain about stuff that much. It's a little unusual for you, but that's the first time we really talked about this. I think it may be a headache, but I don't know for sure. So here's what I'm going to do. I'm going to order a few tests, and I'm going to, see what I can do. Well, here's the funny thing is the people that set up the electronic records and who do the billing cycle don't necessarily care about you or I. So when I go to order this test, which I think, I'm going to give her the benefit of the doubt. I'm going to make sure that, she doesn't have anything bad going on. I'm going to get an MRI because it's the first time she's ever complained about headaches. It's going to force me to put in the diagnosis. Well, I don't know the diagnosis. If I knew the diagnosis without ordering tests, well, I'd be a pretty famous guy, So since I can't, without the benefit of tests, clairvoyantly predict the diagnosis, I've got to put in a reason for ordering the tests that I order. Well, the way the billing people build things is they say, we don't really care about workflow. We don't care about you. We do care about claims denial. So they said, we're not going to let you get that MRI unless you fill out this thing that says, in fact, that T may have a subdural hematoma, a subarachnoid hemorrhage, or a tumor or some other disorder of the brain. And I'm like, well, I think she has a really bad headache. I just want to make sure. Yeah, but we're not going to let you have your MRI. Okay. Subdural it is. There you go. So what we started to notice is the diagnosis codes had more to do with the billing cycle and more to do with the picks that were available. Because heart failure, asthma, diabetes isn't always the same. It's just like the weather. You have good days where it's lovely and your heart failure is fine, your asthma is fine, your rheumatoid arthritis is fine, and you have bad days like the weather where it's not fine. Well, the reality is for people, most of the time, they're okay. You've got them on the right meds, you've got them with the right diagnosis, they're not doing poorly. So the coded diagnosis, either A, if you don't know what it is, you're just filling in a blank to get something done to figure out more, or B, it's not necessarily worrisome heart failure or asthma or diabetes. It's just those things. So what we started to do is to say, it's actually not the diagnosis code, because either A, it's nonsense, doesn't make any sense at all, that's not what they have, or B, it's fine, there's nothing for us to do. So we said, in the world of a pantry, what we're trying to figure out is there somebody who needs our help? And we started to say, the data is not for the purpose of just figuring out categories of diagnoses. The data is for eliciting distress, people who are not doing so well. How do we find them? Well, the diagnosis codes are not going to help us because they're more for the billing cycle, or there's nothing to do anyhow because they're just doing fine. So what we started to look at when we had the pantry available is we started to say, if you were going along doing just fine and suddenly you had 3 encounters to the emergency room, 2 tests for an STD, 1 dose for Xanax, and 2 more for Valium, all in a 6-month period, this is not a happy time. In the world of weather, it's raining real hard right now. So what we said is, that's somebody who needs our help. Now, what's the diagnosis code? It doesn't matter.
Okay.
They are sick. They are displaying what would be a deflection in pattern behavior as elicited by the types of medications, the types of tests, and the types of encounters they're having. So it's one thing to get an albuterol inhaler. It's another thing to get albuterol via a nebulizer machine at an emergency room at 3 o'clock in the morning. Because nobody wants to get up and go to the emergency room at 3 o'clock in the morning. So if you're refilling your albuterol inhaler on a Monday at noon and it's just the handheld inhaler, that's still albuterol, but the route and location and time of these things begin to tell quite a different story. Same drug, different setting, different route. So what we started to say is the pantry now is the ability to look at pattern behavior over time, where we can actually extract people who are doing poorly. And since we can't rely dependably upon the diagnosis code, because that's really for the billing cycle, we actually started to say we can actually find out in advance when people shift their venue, route, or pattern of encounters, meds, or labs. And now I affectionately call this leveraging empathy. If you tell me a story and I respond in a certain way with certain meds and certain tests, then it means that I could be not very concerned. Here's some amoxicillin, 10 days worth, have a good day, no other tests. Or I'm very concerned. Here's 1 gram of IV injected ceftriaxone with a stat CBC, a chest x-ray, and an EKG. I'm
Right.
very concerned that you are not doing well at all if I do that in an ambulatory clinic.
Interesting. Yeah, no, I hear what you're saying with the visiting the ER in the middle of the night to get albuterol. I've been there. My son has asthma. But so would you call the pantry a data warehouse?
Yes, I would say it's a warehouse where we say, why build independently as standalone each and every of these reports every time from scratch when we can begin to say, we're going to use them again. Why don't we just save them and
Right.
then recycle them? And then in the future, we could recombine them with other events. Like, for instance, somebody who gets 4 HIV tests in 6 months. Now, they're all negative,
So
but
time going on, something's happening.
right,
Right.
that's a very compelling pattern because you went 3 or 4 years and asked me for no test. Now, if you ask me for several HIV tests in a row, it means that you're concerned you have HIV.
Mhm.
Now, even if the test is negative, you have no diagnosis of HIV, no positive test, no medications warranted. But now I know in advance you're quite concerned about this, and therefore I should be ready to be concerned and ask more questions.
So it's almost serving predictive analytics type of role as well. Like for your
Yes.
patients, right? Do you ever take your cohort of patients and say, okay, show me those that are, have evidence of this activity combined with that activity combined with this activity. Okay, these folks, I probably have to get in touch with them for X, Y, Z. Do you do that? Or is
Yes.
there some kind of intelligence built into the pantry that's sweeping the data and actually combing through the data and coming up with profiles for patient groups and bucketing those patients? Like these folks are probably at risk for admission. These folks are probably at risk for mortality, dying, expiring early, or whatever the case may be.
I'd like to say we're at the true AI or machine learning stage. I think what I can say comfortably is we've moved beyond just reporting performance on essentially regulatory or billing, performance measures. So we've gotten from that, you're going to tell me what to measure, I'll measure it, I'll give you the answer. We've gone beyond that into now we need to understand why would we work, who do we need to pay attention to more, or who's doing well. Because we need to be able to target the activity of our workforce to A, make them more effective, and B, not burn them out by overweighting them with
Right.
nonsensical process that really is just burning them out because we're doing stuff we hope will do something positive, but we're just not sure. We need to be sharply targeting them. I think we're getting to the point where I think, are able to begin to explore AI as a next step. But as you remember the story of Watson Health, Watson bought from Truven for over $2 billion the claims data, worked with it for years, and abandoned the project. And I think we've learned that same lesson is claims data is for the purpose of billing. It's going to make me say T has a brain tumor or a hemorrhage to get that MRI. And then so it's going to use diagnosis codes for the sake of claims, which are irrelevant for human experience. And we said, no, we have to be superb about the human experience, adequate at the claims.
Okay. Okay. I always like, would you consider the pantry small data or big data? It sounds like it could be a combination of both, but there's a lot of small data activity happening there. Sounds like
Yes. Yeah.
because yeah, go ahead.
Oh, go ahead.
I was gonna say because you're going down to the patient level. I mean, you're collecting data at the patient level and understanding the different behaviors, and you're able to target the behaviors. But of course, you're collecting. I'm assuming that the data is being collected by way of entry into your electronic medical record system. Is that accurate? Are there
It's
other data sources?
we're using more than just the single EHR.
Okay.
But the EHR is our primary data source. Um, uh, we're able to pull in pharmacy, prescription and dispense, lab, ordering, and results, but also encounter. And But what we learned is that the more hand entered by the workforce, the more fragile the data element is. So typed free text, screeners, things like that really weren't adding a lot of value. When you ask somebody in the course of a routine visit for something unrelated, do you drink too much?
Mhm.
And they, of course, say, no, who would? Do you use illegal drugs? Of course not. That would be crazy. Why would I do? I mean, do they tell you the whole truth and nothing but the truth? And what we learned is,
But tell a different story, right?
yeah. And so what we learned is the hard coded, highly, uh, I guess, less subjective would be the result of your glucose, the result of your cholesterol, the fact that you did get a vaccination, that you did have an encounter, that you were prescribed this particular drug. Encounter to encounter, person to person, practitioner to practitioner, those were much more stable elements that we could sort of be more confident that wouldn't vary just on sort of author style.
Okay.
And that's what we use more in the pantry, where we can actually say, if we picked a role of home visiting nurse and we listed the number of people that they saw as encounters, and forget about the documentation, forget about the note, but did those people in the subsequent 6 months have a less than, greater than, or the same likelihood of visit to the ER, admission to the hospital? Then those are also solid events that aren't more subjective or sort how should I say, author dependent.
Okay. Yeah, no, I love the idea of your whole system, the pantry and everything. It must give you a lot of flexibility and providing more and more improved services for your consumers. Um, I would imagine is driving a lot of quality improvement for the population that you serve. And that's my passion. And got a whole talk show about it. I think small data is really powerful because you're able to drill down and focus in on a particular population and particular issues and everything that can help drive quality improvement with specific interventions. So let me ask you something. Would you be able to tell us or share a success story with us where the use of your data tool has played a big part with the population you serve?
Wow. Gee, I'm not sure we have long enough, but let me pick a couple of them.
Okay.
We actually said diabetes is, of course, important. We want to be able to deploy a method that people can, manage themselves as best possible. So we said, let's introduce the Freestyle Libre glucose sensor and make it part of our available dispensable formulary. And we'll have people have an encounter with somebody who will teach them about it, who will put it on the first time, and then we will link it to their phone and then merge it with our data platform, because you can upload to a web server, essentially the results. What we had was a succession of people who got Freestyle Libres who subsequently had hypoglycemic events and needed their meds reduced because their A1Cs went from, mid tens to now below 6 on very little meds that they were on previously.
For the non-clinical folks, that is good, right? That's a good direction. Like
Yeah.
one C less than 7, that's a metric, right? So I just, you know, for the non-doctors out there, go ahead.
But it means, though, that we can actually sharply target
Mhm.
who will likely remain fragile after discharge from the hospital, because hospital discharges, when they warrant home visiting nurses, come in multiple flavors. You need another 2 weeks of antibiotics, and then you're going to be fine. You need your wound changed for another couple of weeks until your follow-up appointment with the surgeon or whatever, and then you're going to be fine. Or you need longer visits than that, because despite the fact that you were discharged from the hospital, you remain somewhat fragile. Now, the reasons for this are, of course, not necessarily helpful because they're all over the map with the diagnosis codes chosen. But what we have learned is, if we do a certain number of visits or interventions or the intervention type shifts, then what we can do is start to micro target people to say, this person may not be safe to stay in their own home anymore. They may be at risk for egregious injury, illness, or cataclysmic, event like hip fracture, fall, head trauma, etc. So we can actually find, based on the type of meds, number of visits, clustering of visits, and follow-up encounter pattern, to say these folks, they're going to be okay. They just needed a little bit more antibiotics. But if you look at the type of meds used, the route they were used, the frequency they were used, this person's going to be okay. They had community-acquired pneumonia. They were discharged to home with some persistent antibiotics to finish out their course. But this person, not so much. So how do we begin to play offense with advanced directives, bringing in people to say, should we look at your home? Is it safe? Do we need to remodel it? Or do we need to look at, some sort of assistance or even home venue setting change?
Do you flag the patient's record in the EHR in any way once he or she is found to fit this particular profile? Is there like a stop code or something that pops up so that, you know,
Really interesting. The EHR is built to make money.
mm,
It's not built to help people.
transactional? Yeah.
Um, so
Mhm.
what we found is the EHR is a transactional encounter-based thing for the purpose of generating a bill. It will never help you do higher quality care.
Okay.
So what we do is build dashboards uh, in our server, and we have our pantry and then our dashboards for each of our teams separate from that. Now, it has pulled from that EHR all the same med rec numbers, phone numbers, addresses, et cetera, all the events. But to be able to surf through your entire impanelments you'd have to open every single chart and peruse each chart. You can't do that. So what we do is we essentially pre-package it for you. Say, we're going to make it easy for you to surf, easy for you to sort, easier for you to refilter, to say, filter top to bottom, highest A1C to lowest A1C, highest BMI to lowest BMI, highest rate of visits to the emergency room to lowest visit rate of the emergency room. So we make it easy for the workforce to be able to get access to and then be able to filter outside the EHR data that has been mostly pulled from the EHR, but it allows us to add other sources should we have them. So here's a good example. Have you had a COVID vaccination? Kind of an important bit of information to know. So there are several sources because you have more than one organization doing COVID vaccinations. So we said, if you've gotten one, we don't want to bring you in and give you another one because they're kind of hard to get your hands on. So let's be effective. What we do is tap into the statewide vaccination database, which is external to ours, and pull into our data warehouse so that we can display in our data pantry a listing for each medical home team to say, here are the 1,472 people on your panel. Here is the number of people that have gotten a completed vaccination series, and here are the people who have not, and here is the locations they have gotten them at.
Wow. Is it problematic to tap into that state registry of vaccinations? Is it like, is that like a hard process or like a rigorous process to get access to that database, or is that not so rigorous?
Initially, you have to make a data sharing agreement, and we send them people who we have a clear established relationship with. So it's not like we can clearly say, just give us everything that you have. We have to say, we are caring for these discrete number of people. Here is their name, age, demographics. If you could refresh for us on a regular basis these names. But once established, what happens for the workforce is this is refreshed every day behind the scenes in essentially an auto refresh. And we do it at night so that it redisplays at 5 a.m. each morning.
That's awesome. That's awesome. That's beautiful. Is it possible we'd be able to see what your system looks like today on this video?
Yeah, I think so. Yeah.
So if you'd like to show us like a de-identified view and just give us a quick preview of what this fabulous tool looks like, that would be great. You can go ahead and hit share screen when you're ready.
All right, well, let's cue some stuff up here.
Yeah, Steve, anytime we can create that click and drill, here's an action list of patients, go get them. It's awesome. I love the activity of putting the data at the fingertips of the providers when they need it. Okay, beautiful.
Okay, so you got it?
I'm seeing it. I'm looking at it. It's beautiful.
All right. So let's look at a simple one. We'll look at COVID screening.
Okay.
So there's a couple of things you're going to want to know. You're going to want to know the big picture. You're going to want to know how many people have we tested, how many tests are positive, how many tests are negative, and then you're going to want to be able to say, and what day were all those tests done? So easily from, I'll say a day that shall live in infamy, March 12th of 2020 is when our adventure began. And you can see not very many tests, but you can see as we went through time this last year, and the red bits are the positive tests, and the gray are the negative tests. And you can see how they were applied in a big picture with a demographic, with a gender, and with with a positive or negative, based on age demographic. So this gives you a big view. But when you drill down, you say, well, yeah, that's great, but I'm a clinic. I'm a manager in a clinic. So I don't want to know every location you have in all of Southcentral Foundation's, places. I just want to be able to say, for the Brother Francis, which is our homeless shelter where we have a clinic, I'm the manager of Brother Francis, and I just want to know how many people have we tested, and how many positives and how many negatives, and and what is the age distribution of them. Actually, let me pick another clinic. We didn't do that much testing in Brother Francis. Let's look in.
Very low positivity rate.
Yeah, we did a lot of those in testing centers. So let's just look. We'll look at 2 North. Okay. So 2 North, a little bit higher, with 466 and just a little over 9,000 tests, and in the clinic itself. But we said, well, there's going to be additional things that we're going to want to know. We may want to know an individual provider. So since I've clicked on 2 North, there are just the providers in 2 North. If I had clicked on all, I'd be able to say, here's all of the providers that work for the organization.
Let me ask you, do the providers themselves have access to this tool? Where they can go and find themselves? And okay, very nice.
Yeah. And then are they impaneled? In other words, are they have an established relationship with a medical home team? What is their age? We can select an age. What is their gender? Or what is the result value? Maybe we're only looking for the positives. So we can look at just the positives and their demographics. And then if I was a senior administrator, I may want to say, well, where were we doing these tests? Because we had multiple settings where we could. And if we did the test while standing in, I don't know, one of our clinics, we may need to do some contact tracing. Or if we did these tests at a fully PPE protected testing location where all our staff were safe, then there's less risk and less worry with contact tracing. So if you notice, we had most of our testing done at a couple of our testing centers. And then this is our numbers over time with tests. But we could look at who was the ordering provider if we wanted to look at an individual ordering provider. We could look at a testing location, just one.
Wow, okay.
Or we could look at all of the values, to drill into there. And then we could say, well, why would we go to another place? Because the topic is still COVID. We might want to say, well, how are we doing with vaccinating people? And then we can say for our impaneled population, as of 4:30 a.m. this morning, we have 22% of our 40 to 49 age demographic fully vaccinated, and 26% of that demographic with 1 vaccination. But you can see there's different for the first shot or the second shot.
Nice.
But we've got almost 12% of the 16 to 39-year-olds.
Very good, very good.
So here's another example. I'll show you another example where we're not looking at, personal health information. We'll look at meds. So we can do this with labs. We can do this with encounters, but meds are a very good one to just show you how the design is. So very often you do things in a very specific way. You say, well, I'm just worried about antimicrobials. So you build a report for antimicrobials, but then another person says, well, I want to know about depression medications or antipsychotics or something else. And we said, well, why choose? Why not just build a platform that has every single medication class? I could pick HIV meds. I could pick opioids. I could pick hepatitis C medications.
Let's
Diddy.
Could we pick opioids real quick because
Yeah,
that's
sure.
big concern nowadays, right?
There you go. So we can look at, these are the various opioids that you can order.
Mhm.
Basically, Vicodin, oxycodone, Percocets, Tylenol with codeine, tramadol, morphine, hydromorphone, fentanyl. Not a lot of codeine or methadone, very little of that. But we can pick then to say, what's the generic name?
Mhm. Okay.
What form was it? A patch, a tab, you know? What was the strength? What was, who ordered it? Because I may want to know who is the ordering provider.
I assume that you have a report in here that can show you by ordering provider the
Yeah,
number.
actually, if I wanted to go by prescriber, I'd click this tab
Okay.
and then I would get the tab.
Okay.
And then I could pick the specific med and the form.
Okay.
Then I could pick a date range to say this is a year, but I could say, well, I'm only concerned with last 6 months, so we'll go here
Oh,
and
wow.
look at the last 6 months.
And this tool was pretty much built in-house, right? This was you all building this tool based on what you needed, right?
It's funny. It comes from the warehouse. It's supplied by the pantry, but all this is a Tableau sort of filter tool. Tableau is a commercially available spreadsheet tool.
Mhm.
It's not, it's like Excel basically.
Right.
But then I can actually also look at what pharmacy dispensed it.
Okay.
So I can see clustering of an individual person who's receiving, an individual practitioner who's prescribing, or an individual pharmacy
Right.
for any drug, any route, any location, any time window.
Wow. A lot of information. I mean, as I'm looking at this, I'm putting on my hat, or when I used to be in the clinic and just thinking of all the different requests. There. One, I'm glad that you have. I like how you have the different views and the different ways you can cut it because everyone has different needs, right? Um, and a lot of folks may look at this and go, "Whoa, there's just so much information. I don't know what I want." So I guess it's really important to really understand what are you trying to answer? What question are you trying to answer before you request anything? Because that will really drive exactly where you go in this tool. Um, yeah, thank you for showing us this. This is awesome. Um,
But it
and,
means that we have the ability to say, change the topic, diabetes. Now pull all the A1Cs,
mhm,
pull all the metformins, pull all the insulins, and now merge them into a new view to say, I want all the name, address, and phone numbers. I want all the prescribers, all the encounters, all the pharmacies. And then I want this lab and I want to match this with this med and in this time window for this particular clinic. So how that works now out of a pantry model from a server that's just constantly refreshed every day is that report takes about 5 minutes to build.
wow, really amazing.
Yeah, you
Yeah,
can actually watch the text. We have essentially design text. We can watch them build it because it's click drag, click drag, click drag. from the build tool. This is just a view tool I'm looking at now, but from the build tool, it's actually very fast.
Wow. See, now this is amazing. And, I just get all, you know, jiggly or whatever you want to call it when I see tools like that. And then even better, being able to design it, but actually using it. I can imagine the staff at Southcentral Foundation are very appreciative of this tool and what it can allow them to do to really, especially the providers, PCPs, to really know and understand their panels and really it must help tremendously in like pre-visit planning and understanding, okay, for this cohort, you have to make sure, even with the providers, just looking at that opioid report, you can see who the top prescribers are. I can imagine someone pulling a report and going, okay, we need to talk to these 5 providers and make sure that they're following protocol, prescribing all of these opioids, making sure that we're in compliance with prescription protocols and whatnot. But I mean, the uses are endless, I can imagine.
Well, it's funny. It's like anything that you are using a sort of, I'll just say, intrusive intervention. Depending upon who you're talking to, it's extremely welcome, or it's extremely not.
It's extremely Big Brother-ish kind of thing.
Yes.
Like you're tracing my every move. But I'm pretty sure it's really driving supreme clinical quality improvement, right? And that is the ultimate goal, right? To improve the lives of the patients that you serve, population you serve, keep them healthy. So I really love that tool. I love you guys. Like I said, you're a huge inspiration to me, especially when I was working with the HIV/AIDS care clinic in Manhattan. So I know all of those folks will be listening to this recording later on and going, oh, yes, we remember Southcentral Foundation. Yes. But definitely, I would love to have you back on at some point and we can continue the conversation and maybe look at some other stuff, especially after we get further along past this COVID business. And when you guys start studying the COVID population and looking at all of their issues and comorbidities that have popped up because of COVID, that would be great. But we have come to the end of the program. And I'd like to thank you so much, Steve, for joining me today. I really enjoyed learning more about Southcentral Foundation and the data mall and what you all are doing with your small data and your big data. And I will definitely be keeping an eye out on more developments. So thank you, listeners, for tuning in to watch us today. To subscribe to the podcast, you can find us on Spotify, iHeartRadio, and TuneIn. Look up Let's Talk Small Data with T, no apostrophe. And you can also visit eima-inc.com and click on Let's Talk Small Data to learn more about the podcast. And this brings us to the end. So have a wonderful day. And remember, unleash the power of your small data. It's your most strategic asset. See you next time.
This episode is brought to you by Effective Information Management Assistance, specializing in healthcare small data and offering expertise that goes beyond technology. Visit www.eima-inc.com to learn more about Emma and the podcast, Let's Talk Small Data with